We take a great pleasure in welcoming Professor Dr. Ramachandran sir, one of the best clinicians who did his MD in JIPMER, former director of ICH, currently the head of Department of Pediatrics in SRMC. We also cordially welcome Professor Dr. Thangavelu sir, an alumni who did his DCH and MD in ICH, who is a combination of professionalism and dedication in patient care. At present, he is a consultant in Mehta Hospital.
7 years, Master Afzal, reared by non-biological parents of third-degree consanguinity from Trichirappalli, presented with fever for about 6 months. History of presenting illness. The child had fever which was insidious in onset, low grade, intermittent, 2 to 3 episodes every month, which has lasted for about 3 months. Each episode lasting about 3 to 4 days, not associated with chills, rigors, or forehead sweating. Each episode settles spontaneously with antipyretics. History of abdominal distension for 3 months, insidious in onset, non-progressive, diffuse pain, dull aching, it was not radiating elsewhere, associated with history of abdominal distension for the 3 months, generalized distension, progressive for about 2 weeks, now reduced with treatment during hospitalization for the above complaints. History of EC fatigability for about 3 months, history of not gaining weight for past 6 months. History of loss of appetite, history of hospitalization for about 2 weeks. During the 4th month of illness, he was evaluated for fever, could not attribute any etiology. The treating physician proceeded for a bone marrow study. Bystanders were not given any definitive diagnosis. He was discharged with some oral medication. The child was apparently normal for about 1 month after discharge. Then he developed prolonged fever with anemia for about 2 weeks. Current episode on account of which he was transfused 1 unit of blood product. He was referred back by the treating physician to ICH for further management. History of gum bleeding, first episode noticed while brushing teeth 2 weeks back, which settled spontaneously. Past history of skin rash, raised pruritic erythematous non-tender rash all over the body with involvement of the lips attributed to the insect bite, settled with topical application of a lotion. 3 similar episodes of skin rash, probably an acute urticaria. There is no history of acute watery diarrhea, vomiting, no history of breathlessness, cough and cold, no history of chest pain, palpitation, no history of bone pain, joint swelling, night cries, no history of swelling in the neck, axilla or groin, no history of otorrhea, recurrent respiratory tract infection, skin and soft tissue infection, no history of dysuria, oliguria, seizures, visual disturbance, headache, jaundice, sore throat. There is no history of contact with an open case of tuberculosis or recent travel outside our country. No history of chronic medical ailments other than the presenting illness mentioned above. No history of documented allergens. No history of sleep or behavioral disturbance. Developmental history, the child...
Can we stop here?
Yes, sir.
So, we are just discussing the approach. You don't have to much worry about the final diagnosis. Okay. So, looking at the approach, do you think this child's problem of the fever, is it the same problem which is continuing, or do you think it is, do you think this fever is 6 months, you said the fever?
Yes, sir.
Is it the same problem continuing over the last 6 months, or it is in between occurring some problems?
He continues to have fever, sir. Every month he used to have 2 to 3 episodes. Each episode lasting...
In between how many days he is normal?
He is normal for about 1 week, sir. Then he develops fever for 2 to 3 days, sir.
Okay. So, what other question you would like to ask in this interfebrile period?
Whether the child was absolutely normal during the interfebrile period, was he on any medications, as he developed some other symptoms like abdomen pain?
How does it help you?
Sir, during any illness in the intercurrent period...
What does it rule out rather? See, the
any
child
chronic
who gets fever.
Chronic malignancy like that, sir. Chronic infection or a malignancy.
The problem is not something which is there every day, isn't it?
Yes, sir.
So, it is probably rules out certain things which we attribute to chronic fever,
yes,
or long duration fever. This seems to be the recurrent episodes, yes, rather than one continuous thing over the last 6 months.
Yes.
Of course, there may be some differences in the way you take history and get the information. From what we could get was, this child over the past 6 months gets fever about 2 times, sometimes 3 times. And the mother swears that at no time it lasts more than 3 days. And the child after 3 days is normal for about 10 days to 14 days. So this practically rules out some problem which is there continuously, like tuberculosis, okay, or a malignancy, which you expect the fever is not expected to settle down by itself. So, and in between the child is quite active and playful and eating well, sleeping well. So it tells you that the child is not having something which is continuous and disabling the child. Seems to be some discrete events rather than a continuous problem. So you look at your differential diagnosis based on the analysis of the history. That is what we are just trying to say. Okay.
Chronic PO or intermittent fever?
Sir,
what do you think?
It was intermittent fever initially, sir, for which he was hospitalized. He was evaluated extensively for fever for about 2 weeks, and now he is 1 week in our Institute of Childhood, sir. Probably he might be a case of PO, sir.
So that brings us to the definition of PO.
What is the definition of PO?
Sir, pyrexia of unknown origin is any hyperthermia which lasts for about 3 weeks.
Any fever.
Okay. Fever
After intelligent, invasive, ambulatory investigations for about 1 week of hospital period, sir, or 3 days of outpatient visit. Or
3 weeks.
3 days.
3 weeks.
So the classical definition is 3 weeks. 3 weeks of fever, in which 1 week inpatient evaluation doesn't reveal etiology, but this is modified by Fajan and Cherry. Okay, you would have heard of the infectious disease book, Fajan and Cherry, is that in pediatrics probably a 1 week fever in which evaluation, clinical evaluation and obvious, first line investigations do not reveal a cause. What is the difference between PUO and fever without source or fever without focus?
Sir, fever without focus, PO is usually after 1 week of hospital stay. After all the relevant investigations accounting for fever, we term it as PO, sir. Whereas fever without any foci of infection might be a hidden occult. We should search for other occult.
So generally the cutoff is the duration. A fever of less than 1 week where you don't find any obvious focus is called fever without focus. A fever which lasts for more than a week, when all these things which we described, is called generally pyrexia of unknown origin or fever of unknown origin, or some people call it a prolonged fever also. Okay. So this child looks more like a discrete recurrent episodes of fever rather than one continuous pyrexia of unknown origin. Okay. Do you agree on that?
Yes.
Is it okay?
Yes.
Agreeable? Okay.
Could you
And
get
the other
any-
thing which helps you is, in between these events, the interfebrile period, the child is quite active, eating well. Even during the fever, according to the mother, the eating and other activities are not affected much. Okay.
Could you get any clue about the type of fever? No, each time, according to the mother, 3 to 4 days the fever lasts. Could you get any clue about the type of fever? Whether it's a simple viral fever or malaria? Any
There is
any
no
historical
malaria.
clues for that?
Possibilities of malaria is unlikely, sir, because there is no fever with the chills and rigor. There is no obvious evening rise of temperature, and there is no obvious foci, sir, like an autoria or a breathlessness. Or an
Let us say a child has fever of 3 days. Without any intervention, the fever stops. What other clue you would like to have?
Probably.
You thinking it's not likely to be malaria. What else? This discrete episodes of fever. What other things you like to ask?
Probably a viral fever, sir.
So what are the symptoms? Something like a URI symptoms or some other contact history, okay, or any myalgia.
Yes.
And even without taking any medications or any antibiotics, the fever stops. Okay. So that may give you a clue. What are the other reasons for a periodic fever, recurrent fevers? You would have heard of this term, isn't it? Periodic fever.
Sir, there is
PFAPA and other things.
So genetic syndrome, sir. Genetic syndromes for periodic
No,
fever.
clinically, what is the clue?
Sir, usually they will have conjunctivitis, sir. Cold-induced conjunctivitis, skin rash will be
PFAPA,
there.
remember PFAPA.
Sore throat will be there, sir.
Okay.
After ulcers will be there, sir.
Okay.
Exposure to cold, the child will get a conjunctivitis. Skin rashes will be there. sir.
Lymphadenitis.
Lymphadenitis
Okay.
will be there.
So this may be, if they are there, probably you can even think of a PFAPA. Okay. So this is the other things of, you think of this child who is not very much systemically affected, but just has a fever which is very short duration. So that is the way you have to approach this child. So think of other things like a non-malignancy, very chronic infections, what are all the possibilities? Periodic fever, whether it is possible, or whether it is just the child is having some other non-inflammatory causes of fever, like whether anything to suggest any autonomic disturbance, okay, anything to suggest some sweating disturbance in a child. Such things should come to your mind. Just for, we are discussing as an approach, nothing else. Okay.
Development, the child had appropriate milestones for age in all domains. Immunization.
Was this child any time told that the child had anti-malarial was given to this child?
No, sir. They did not take any anti-malarial.
What is the treatment used to be given during these episodes? Was the mother told what type of treatment the child is getting?
The mother was given syrup paracetamol, sir. The child was given syrup paracetamol and one capsule. The mother doesn't know the name, sir. He was given one capsule, sir.
Okay.
Any point of time, any investigation has proved a diagnosis in this. He has been several times visited the doctor as an outpatient, twice hospitalized.
Yes.
Any point of time, did he get any clue about the diagnosis?
Sir, the bone marrow study was suggestive of hemophagocytosis, sir. But the child was not given a definitive diagnosis for cause, sir.
Even after the investigation, he continues to have fever or no fever?
He was, after discharge, he was
making the
afebrile
diagnosis.
for about 2 weeks to 2 weeks, sir. Then he again developed fever, sir. For which, at the time of reoccurrence of fever, he developed anemia, sir. He was given 1 unit of blood and then he was referred to ICH, sir.
Okay.
Now, what are the situations in which a child with recurrent fever requiring a blood transfusion? This is a child with recurrent fever, now has been given transfusion.
Sir,
Will you give any clue about the disease?
probably a malignancy, sir.
Okay.
Probably a malignancy. Causes of pancytopenias.
Can it be an unconnected fever episodes with some other pathology like hemolytic anemia? Will that be a possibility? Because
Sir,
fever is not very significant, 2-3 days of fever only subsides.
The child was not transfused previously, sir. No jaundice was noticed.
Only once it was
This
transfused.
was the first time he was noticed to have anemia, sir.
Can some anemia be following this fever? You are telling this child had some abdominal distension also. So you would have examined and you would have found something in the abdomen. So what else in the abdomen which can cause anemia, which can predispose to anemia?
Hypersplenism, sir.
Hypersplenism. That is another possibility you can think of. Especially with some bleeding you are telling.
Gum bleeding.
Whether there are other elements of blood which are also depressed. That is another possibility you can think of.
Yes.
And certain terms you can probably avoid. Don't tell the relatives as bystanders. Okay, they are not bystanders. Bystanders are totally unrelated people. You during an accident you call them bystanders. Okay?
Sorry, sir.
That's just a simple correction I wanted to tell you, right? Okay. And anybody, does malaria in endemic areas, does it have to present with the typical symptoms of chills, rigors and other things? Doesn't have to. Because of the increased immunity basically, or many subclinical attacks when they were young, sometimes they may not have even the typical symptoms of malaria in endemic areas. Okay, so please remember that typical history of absence of chills, rigors doesn't rule out malaria, episodes of malaria. Okay, only thing is spontaneously becoming all right without treatment is rather uncommon. Okay.
Socioeconomic history. He belongs to neutral family, no overcrowding, Pakka house, cross ventilation present, access to safe drinking water
What
present.
is the neutral family?
Nuclear, huh? You said nuclear. Spelling mistake or
It was spelling mistake, sir. Sorry, sir.
you are ready?
Now all of them woke up, sir.
Okay.
No, sir. Sorry, sir. Separate bathroom and toilet facilities, separate sewage and sewage drain, no exposure to pets. According to modified Kupuswamy socioeconomic scale, the family belongs to upper middle class. Nutrition history. He has a deficit of about 50 calories and he has a deficit of about 10 gram protein, sir.
Okay, I just pick up one thing in your nutritional history. You have written 1 cup of sambar, which gives 50 ml
Yes.
and 90 calories. What is in sambar which gives calories?
Sir, it's a handful of vegetables, sir. Dal, sir.
This child get in 1 cup of sambar, handful of vegetables. Then only vegetables will be there. There will not be any sambar.
Sir, usually the sambar is made up of handful of vegetables,
Oh, is it so?
dal.
protein is only 1 gram. It should
See,
contain dal only.
yeah.
No? More of dal.
It will have dal.
More protein than less calories.
So that is probably the reason your protein has come as deficit. Probably the calories also would have been deficit. Because each time sambar you have just inflated the calories. Okay. Sambar, the only thing which will give calories is the dal which is present. And if they put lot of oil, these are the two things. If we take only dal, if you're going to get only 1 gram of dal, definitely the calories will not be 90.
But unlike a Karnataka sambar where the sugar is added. That is likely.
So look at why this, this thing itself you can pick up that there is something wrong. Why is so in the nutrition history? Generally, by and large, in our diet, in nutrition, the calories will be deficit. There will be a difference of about, if the calories are, the protein is 100%, the calories will be 70%. Okay. The protein is 90%, 90 of the required, calories will be 60. There will be around 20 to 30% deficit difference between the proteins and calories. Unless they are a total fisherman, they take lot of fish, high protein diet. Otherwise, this difference will be maintained. Okay. So please, when you do this, have a check in your list. Okay. Because some examiners, just for the sake of having a different approach, they may ask you a lot of things about nutrition. You are not expected to make mistakes in nutrition history.
Yes.
Diet history. Yes. Sorry? Is it so?
Anthropometry, his weight is 19 kg, weight for age falls between 10th to 25th percentile. His height is 121 centimeters, height for age between 25th to 50th percentile. His BMI is 13, between 5th to 10th percentile, sir. This was the TPR chart during his hospital stay in our ward, sir. This TPR chart is demonstrating a remittent type of fever.
This is the type of fever he is having.
Yes, sir.
Mother told when he came to the hospital 10 days, there was no fever at all.
No, sir. Last 2 days he is afebrile, sir.
But this is 2 days chart, huh?
No, sir. This is at the time of admission. Last Friday he got admitted, sir.
Almost
Okay.
10 days. No?
So from then onwards, every day he is having fever.
Yes, sir.
Right.
10 days.
Our
Summary.
hospital, they are taking like this, huh?
Sir.
Just show.
Yes.
Okay, I am very surprised. They take like this in your ward. Huh? Our sisters record like this. There is a 2 a.m., 3 p.m.
3 p.m. to
Okay.
6 or 8 only.
Fine. This doesn't look like our hospital record. Okay, definitely. Because I have been in ICH. I know. Okay. Yes. Right.
Summary.
It looks very clean. Okay.
7 years boy with prolonged and recurrent fever, generalized abdominal distension with severe anemia requiring blood product transfusion, 1 episode of gum bleeding, not gaining weight for the past 6 months, with loss of appetite, yet no bone pain and or night cries, with no obvious foci of infection, past history of acute urticaria. I have considered possible causes of pyrexia of unknown origin. I wish to proceed for the examination, sir.
Consider recurrent episodes of fever. Don't put it as pyrexia of unknown origin.
Yes.
It's not a continuous fever of more than 2 weeks. Okay. Your definition of the case itself may be a bit questioned. Okay.
Yes.
So please get your terms properly so that your approach will be appropriate. That's the only thing which you are telling. Okay. You may be correct in your diagnosis, final diagnosis. But from what you are saying, you are just telling this may not be the right way to say. Yes.
General examination.
What are the cause of recurrent fever leading to anemia requiring transfusion?
Recurrent fever with anemia.
Now, if you are going to take this recurrent fever, what are the differential diagnosis you will consider
Sir, possibly
at the end of the history?
Possibly chronic malaria, sir.
Okay.
If he belongs to North India, this child belongs to South India, sir. So I am not considering Kala Azar, sir.
Okay.
He may be a case of hemolytic anemia.
No, you finished the infections. Only chronic malaria?
Tuberculosis is a possibility, sir.
Recurrent fever.
Recurrent
This is
fever.
unlikely. What is the recurrent fever? You said some other North India, what can be the
Kala
equivalent of
Azar.
malaria? Kala Azar.
Kala Azar, sir.
Can produce recurrent episodes of fever. Okay. Whenever there is a burst of this release of this infective material, they may get fever. Okay, in between. Right? Anything else?
Sir,
Recurrent fever?
Even an undiagnosed urinary tract infection can have that, no? Because not proved and it's not put on prophylaxis, he may develop a recurrent UTI.
Can immunodeficient people can have recurrent fever?
yes, sir, they can have, sir, but
They
he is
can have.
thriving pretty well, sir.
No. We are just discussing the differential diagnosis.
Okay,
We are not come to the examination part of it. Okay.
PAD is a possibility. sir.
Okay. Immunodeficiency, we are not talking about the primary immunodeficiency. Some other acquired problem. Okay.
HIV, it's a
Yes.
possibility, sir.
Those things also you can keep in mind, possibilities. Okay.
SLE, sir.
And what about,
Connective tissue disorders like SLE,
okay. Good, correct.
rheumatoid arthritis, or
Usually the
Systemic onset.
presenting as fever, you are likely to get more in systemic onset, which is usually a continuous
Sogia,
fever.
sir.
Okay,
Systemic
not a
onset.
recurrent fever. Okay. Can it be, again, going back to periodic fevers?
yes, sir, it can be a periodic fever, sir.
Is possible? Periodic
Familial
fever is
Mediterranean
possible?
fever,
Okay.
sir. General examination, the child is conscious, oriented. He was febrile 2 days back, sir. Pallor present, cheilitis, glossitis, angular stomatitis, dental caries present, BCG scar present in the left arm, Mantoux site present in the left forearm, no induration, no dysmorphic facies, no icterus, cyanosis, clubbing, pedal edema, no generalized lymphadenopathy, sir.
Afzal, திரும்பு.
Hair, no alopecia, skin, no pigmentation, petechiae, hemorrhagic spots, pruritus, leg ulcers, nails normal, eyes normal, no keratoconjunctivitis, no choroid tubercles, fundoscopy, no cherry red spots, oral cavity, no aphthous ulcers, thrush, no sternal tenderness, no eschar. Vital signs, blood pressure 100/60 in the right upper limb supine position, heart rate 120 per minute, normal volume, regular rhythm, felt equally in all peripheral pulses, respiratory rate 30 per minute, no retractions, thoracic type of breathing, saturation 99% room air, warm throughout, capillary refill time less than 2 seconds, 3+2+. Systemic examination, perabdomen is soft, distension is present, umbilicus is present in the midline, all quadrants move equally with respiration, no visible scars or sinus, liver span measures about 9 centimeters, firm, sharp margin with smooth surface, it is non-tender and non-pulsatile. Spleen,
So generally when you tell about liver, you first tell palpable so many centimeters below the right costal margin in the midclavicular line, then you tell about the span.
it is 2 centimeters palpable below the right costal margin, sir,
Okay.
along the midclavicular line.
Right.
Spleen is 7 centimeters below the left costal
What is
margin.
the character of the liver?
Sir, the liver is firm, it has sharp margin, smooth surface, it is non-tender and non-pulsatile, sir.
Okay.
Spleen, it is palpable 7 centimeters below the left costal margin. Spleen is hard in consistency, notch felt anteriorly. It is non-tender, no splenic rub is heard. Distended veins present over the abdominal wall.
So you are bringing both palpation and auscultation together. Huh?
Sir,
You are talking about the splenic rub. Okay. So
yes. There is no ascites, flanks are free, no guarding, no rigidity.
So when you
Hernia-
are talking about distended veins, you have to be more specific. Is it seen in the central portion
Sir,
or
it
in
is
the
present in
flanks?
the epigastrium, sir.
Epigastrium.
It is present in the epigastrium. Sir.
Okay.
Hernial orifice is free, external genitalia circumcised, else normal, sir. Normal bowel sounds are heard, sir. CVS S1, S2 heart sounds heard normally, no murmur. Respiratory system, bilateral air entry equal, no added sounds. Central nervous system, no focal neurological deficit. Spine and thyroid gland, normal, sir. Diagnosis,
You have to change it. Okay.
Yes.
Recurrent fever.
I will offer a differential diagnosis, sir.
See, you said something about this child's parents.
Yes, sir.
Yeah, what is it?
See, this child is reared by non-biological parents, sir.
What we are interested is more about the actual parents, whether they were
Sir.
consanguineous or non-consanguineous.
His real parents are non-consanguineous, sir.
Why?
Sir, his real parents are also consanguineous, sir.
Consanguineous.
At present, he is reared
No,
by.
we are not, that may
Okay,
not be of much use except for social reasons.
Yes.
What we are interested as far as the disease part is concerned, about the parental consanguinity.
Consanguineous marriage only. Sir.
Consanguineous marriage.
Yes.
How? How much?
Second degree consanguinity, sir.
Uncle niece or something?
Yes, sir.
Okay, right. Why is it important in the context of something which you are discussing?
Sir, possibly hemolytic anemia, sir.
Yeah, you have
Like
to
a
keep that in
thalassemia.
mind. And also you have to
Sickle
know,
cell.
tell about whether the parents, any one of them had any problem, any hemolytic
sir.
to suggest.
There was no history of malignancy or
No, jaundice.
there is no
Or
jaundice in family
stones,
members.
gallstones in the parents, mother.
Gallstones I did not ask, sir. I asked for jaundice. There was
Gallstones with relevance with hemolytic disease.
Sir, sickle cell anemia we can get, sir.
Yes? Spherocytosis. Okay. That's the one which is autosomal dominant. Even one of the parents may have it, need not be even a consanguinity. Even the mother. Sometimes if you ask a history of gallstone removal, you may get it. Okay. Even the mother, sometimes we are diagnosed this after diagnosing in the child. The mother or father may be diagnosed. Okay. Keep that possibility in mind. Yes. Okay.
Sir,
Is there anything in the facies? Is there anything to suggest a hemolytic facies, this boy?
there is somewhat maxillary prominence is there, sir.
There is a slight maxillary
Slight
prominence.
maxillary prominence
See,
is
he
there,
has
sir.
got an open mouth. Okay. There is the upper incisors are more
Yes, sir.
the maxilla, upper maxilla is, I'm sorry, the upper jaw is more prominent. Okay. Right. Other head is not, nothing suggest. Okay. You said something like bleeding. Is there anything wrong with the gums?
No, sir.
Any gum hypertrophy or any problem in the gums? Nothing.
There is a teeth are widely placed, sir. Other
That's
than
all.
that, I cannot appreciate,
Okay, fine.
sir. Sir, out of the differential diagnosis,
You go ahead with that
Sir,
because you have put it as a PUO. You have put all these differential diagnoses.
Yes, sir.
All right, no problem.
sir, the first possible diagnosis for this case could be malignancy, sir, of which I will rate chronic myeloid leukemia as my first differential diagnosis, sir. Sir, sorry for context of taking this case as pyrexia of unknown origin, sir. Considering
Doesn't matter.
recurrent
What
fever,
features make you to think in terms of?
sir, recurrent fever for about 6 month duration, sir.
Okay.
Despite adequate investigations, the child continues to have fever, sir. So with the splenomegaly, hard splenomegaly, firm hepatomegaly, I will consider malignancy, sir. There is no jaundice and there is no significant cervical lymphadenopathy, sir. But 1/3 of cases of Hodgkin's lymphoma can present without cervical lymphadenopathy, sir.
Okay. So generally, it's very uncommon.
Yes, sir.
Okay, but maybe rarely, right? Usually, the non-Hodgkins are the ones which may not have cervical adenopathy. They may have adenopathy somewhere else. But conventionally, we expect Hodgkin's lymphoma at least after 6 months to have some cervical lymph nodes. May not be in the first month. Okay. What else?
Myeloproliferation disorders, polycythemia vera and chronic myeloid leukemia, sir.
Myeloproliferative disorders like CML.
CML, sir.
Okay.
Mainly because of the splenomegaly that he has, sir. It is approaching the umbilicus, sir. It is hard spleen, sir. And he is having anemia. He had one episode of gum bleeding, sir. So I will consider.
The anemia will be mild or moderate to severe. If you are thinking in terms of myeloproliferative disorders, the anemia will be mild like this or it will be moderate or severe?
Sir, anemia is usually it is a mild anemia, sir.
See, this child has got a splenomegaly which is quite massive.
Yes, sir.
At least moderate splenomegaly. Child is symptomatic for 6 months. Do you expect the anemia to be only mild like this?
No, sir. He required one unit of transfusion.
Whenever you are discussing a differential diagnosis, you have to put the points for and the points against. That way, the examiner feels that, okay, you have thought about all possibilities. Nobody knows, nobody may be 100% right. But when you are discussing, you put it that way. I am thinking of this myeloproliferative disorders because of, you rightly said, large spleen. But there are certain things which are not fitting, like the anemia is mild. Like this you can say. Okay. Next.
Third thing is hemophagocytic lymphohistiocytosis, sir.
Primary or secondary?
Sir, I'll consider secondary, sir.
See, that is again quite an acute illness, continuous.
Because it's
6 months HLH without treatment, very unlikely.
And other
Don't go by
features,
the
no?
previous somebody diagnosis. You
Okay.
make your own diagnosis.
Maybe you can change the order. You put a big list of orders.
Yes,
can you change any one of these to the first?
Sir, I will put. Sir, I will put chronic malaria, sir.
You want others, sir?
Chronic malaria.
Oh, so,
Others, you can call 2 or 3 people.
so
to
those who are in favor of Hodgkin's lymphoma in this child, raise your hands. First diagnosis. First diagnosis. You have to at least raise at least for one. Hodgkin's lymphoma, raise your hands. Or any of this malignancies. Okay. Low grade or whatever the malignancies. Okay. Second is, we go this group, chronic malaria, Kala-Azar, tropical splenomegaly. Raise your hands. Anybody? Okay, there are some people who are thinking like this, maybe around 30 or 40. A disseminated, we rather call it disseminated tuberculosis because of the organ involvement. Disseminated tuberculosis. Okay, some
he
people
never
are
had
there.
any respiratory problems.
No, sir.
Okay.
Or GI problems like diarrhea, respiratory
No, sir.
problems too.
Can it be any of the rheumatological connective tissue disease like a Sogia you have put?
Yes, sir, it can be a. But there is no lymphadenitis, sir, in this case.
It's not necessary.
He's having fever, hepatosplenomegaly, persistent fever spikes is present. It can, but there is. But there
Sogia?
is no arthritis, sir.
Sogia? Anybody? Some people are.
Parliamentarians, please respond.
Only one diagnosis. Only first diagnosis we want. Differential diagnosis, anything can come. Okay. Right. Periodic fever, PFAPA or familial Mediterranean is uncommon. PFAPA or any of those genetic variants. Okay. There are about 2 or 3 people. Okay.
Can this be a totally different, fever is a different pathology or organomegaly is a different pathology? Can it be a hemolytic anemia with some recurrent fevers? Will it be possible? Because they also made out some
It can.
Malar hyperplasia, all that. Will it be possible that it could be a hemolytic anemia or a double heterozygous like hemoglobin ST or something like that? Possible?
He can be a. His parents are consanguineous, sir. He can be a case of thalassemia minor, intermedia, G6PD. It can be a possibility, sir.
Can it be a storage disorder with some fever, intercurrent fever due to some other reason?
Yes, sir. Lysosomal storage disorders like Niemann-Pick, Sandoff.
So keep those possibilities. See, when something is not very typical, then the typical things you cannot say. You have to think of other things also, possibilities. When in this child, the striking feature is the fever is not a continuous one, and in between fever, the child is well preserved and active.
Yes.
Okay, and it occurs only not more than 2 or 3 days in a month, and usually maximum 3 episodes, sometimes only 2 episodes.
Yes.
So that possibility, and the child is not very sick or very severely anemic or having anything like bleeding, continuous bleeding or lymphadenopathy in this child. Okay.
Bone tenderness, nothing is there except hepatosplenomegaly.
So it's a difficult thing. Okay, I am not saying that it's easy, but think of the other possibilities. You'll have to then argue it out. Sir, this is nothing, not a typical of this, but these are the differentials I would like to consider. Tell your first one diagnosis first, then you can go to the other things where there may be 2 diagnoses.
Sir,
Okay.
my diagnosis will be myeloproliferation disorder, sir.
CML. Like
Considering
CML.
the age group,
Okay.
considering the hard splenomegaly,
Okay.
he had one episode of severe anemia to the extent of blood transfusion,
Right.
but there is no bone pain, sir.
Do you think many times he was this thing tested, CML would have been missed? Very unlikely, no?
Yes, sir.
Yeah. See, it will be easily picked up in a peripheral smear. Okay. Very unlikely that a CML would have been missed. Easily they would have done one peripheral smear and picked it up.
And bone marrow also was done, so I don't think they would have missed it.
Okay. So in the context of this thing, you think what is more likely? Okay. So you can even say CML I had thought of, but in the previous test, other thing, there is nothing, no evidence. So that's why I am not thinking of that as the first. I am thinking of something else. See, it is up to you. But whatever you say, you have to say the positive or negative things because it's a differential diagnosis. We are not yet having a definite diagnosis in this child. Correct?
Yes, sir.
Okay. Right. Any questions till now? Anybody wants to ask any questions? You can answer, sir, please. Please ask and answer.
No. Periodic fever, is there history of repeated periodicity to bring in the differential diagnosis? Of course, it is an important condition which is
It
now,
occurs according to him once in 2 weeks or 3 weeks.
So how long
But
now?
there is 3 days.
Okay.
But there is no lymphadenopathy or oral ulcers or any such thing in this child. That he has mentioned. Sir is so attentive. Okay, sir. I had to be careful, sir. Any other thing? Anybody wants to ask? There is, don't have to go. I don't know anything about this child's ultimate diagnosis. So it's only the approach which we are just discussing. Okay. So if anybody who has a question, you are not agreeing with any of the things which we said, or you want to give some other differential diagnosis, you can say. Something like Kikuchi's and other things you can think of. Okay. These are also the other differential. If the fever is continuous. In this child, it's not a continuous fever. The fever has been continuous, I definitely agree, is Hodgkin's, disseminated tuberculosis, Kikuchi's, other chronic infections like brucellosis, all this will come into picture. So it's that particular case, on that day, you have to make the differential diagnosis. Okay? You have some doubt, no? You are not agreeing. Yeah, you give him the mic.
Yes, sir. My doubt is, sir, child is having fever on and off for 6 months duration. Only during the spike of fever, you will be lethargic and dull. Usually, connective tissue disorders during fever spikes will be very lethargic and restless, and after fever, will be very active and playful. Can be a connective tissue.
Can you tell which connective tissue disorder?
Usually, Sogia, they will have during the spike of fever, they will have severe fever.
Sogia will be there for 2 to 3 days.
Prolonged fever.
Isn't it? It's a very prolonged fever. Okay. This the picture he put for a fever temperature chart. It will go on for 2 weeks, 3 weeks in Sogia. Okay. That's why we are not thinking of Sogia. Otherwise, you are right. Very right.
The fever spike, what they are doing, temperature was daily.
Yeah.
Spike of fever,
Correct.
almost 7 days.
Correct. Any other clue you will get if it is a Sogia? Rash. During the peak of fever, you may get a rash. That will again tell you that probably it is Sogia. And you need not have an arthritis or anything during the initial few months. It can appear later. Other things like JAA, along with fever, there must be some joint symptoms. This child doesn't have any joint symptoms. That's why we are not putting in other types of connective tissue disorders. For SLE, again, there is possible, but again, the fever is occurring repeatedly. That is also possible with SLE. But there is nothing else like any ulcers or any other thing. And the child is not very sick or looking lethargic, any hair loss. These are all missing. But among the connective tissue disorders, SLE is something we can keep in this child. Because there has been some bleed, there has been anemia, recurrent fever. Okay? So that is a possibility one can keep in mind. We have 3 minutes. Okay. What do you want to say? Oh. Tangale, you want to say?
Sir, periodic fever is a possibility, sir. Though it is an uncommon diagnosis, he has early onset of
uncommon fever. Things you keep last.
Yes, sir.
See, think of some common conditions, as said in repeatedly, which has some difference in presentation, and also you have to take the history also with some degree of pinch of salt. Okay, whether it is really correct, everything has been really said. You can even ask the physician who has seen before. You can even contact him, is it the type of fever he's been seeing? Okay, so don't go by just because we are saying this, don't go by that 100%. You keep your possibilities because you have come to some examination, you have found some other things. Okay, so don't be this thing. You can say that it's not very typical, but still the other things are more common. I will think of them first as an atypical presentation. You can argue like that. Okay. Yes. Anything in the investigations which we got in this child?
Sir, in investigations, here CT ultrasound has shown hepatosplenomegaly, sir, and rhinomegaly was found. So we proceeded for CT abdomen, sir. In CT abdomen, they find many mesenteric, pericaval and para-aortic lymph nodes.
Size?
One large node in the left iliac fossa measuring 5 into 4 centimeters.
5 centimeter?
Yes, sir. Okay. So they asked to consider lymphomas bar acute leukemias.
Okay.
Sir, smear study is normal. It shows normocytic normochromic anemia, sir. Platelets count normal, seen in good clumps. Indices, RBC indices are normal, sir. WBC count is normal, sir.
Retroviral has been done?
Huh?
Retroviral was done?
Retroviral is negative, sir. I'll show that.
So I think this thing is not wrong. What only thing is you have to say certain things which is not typical, and you can tell that. Okay. And we have seen sometimes patients like Hodgkin's. We had a case from West Bengal, 18 months, recurrent fever. These are all atypical. We think that the fever should have been occurring daily, but he was having fever once in 3 months, once in 2 months, repeatedly the lymph node biopsy done. Ultimately, it came to be as positive for Hodgkin's. So it is not that every case you will have an answer in the first time itself. You will have to look at it, keep at it in children with a prolonged or recurrent fever. The diagnosis may sometimes, the other person, the third person who is lucky will get the diagnosis. First two good physicians also may miss it. Okay.
Thank you, sir.
Thank you so much. You presented very well.
Thank you, sir.
We really enjoyed talking with you.
Thank you, sir. Thank you, sir.